Good morning, everybody. It's a pleasure for me that I have been given this opportunity to speak today, being as a teacher. And I see so many of my teachers here in front of me rather than the students. My today's topic is how to crack the conundrum of arrhythmias from ECG. Now, when I was preparing slides for the last 2 or 3 days, I thought that, yes, I have understood a bit better than previously. And today morning, when I received one ECG of arrhythmia, I was not sure about it. So the confusion will always continue. However, I have tried to take a few important ECGs which comes to the emergency or in our CCU. So tachyarrhythmia, bradyarrhythmia, regular, irregular. So this is our first case, 80 years male with previous AMI, 25% EF, recurrent syncope. So in presence of, definitely there is a structural heart disease, white QRS tachycardia, regular, we should consider VT. If you go by the Brugada criteria, we see that there is concordance up to V5, but V6, it's not there. Not sure about the VT. Number 2, we see from the onset of, in the last V6, if we see from the onset of R to the nadir of S, it is more than 100 milliseconds. So it is likely VT. Then there is no clear AV dissociation. And if we go by the morphological criteria, you again go back to V1. I don't have a pointer. If we see from the onset of QRS to the nadir of S, there's a notching there in the 4th or 5th beat. Along with there is a slurring, and that is more than 70 milliseconds. I have measured it with an axis deviation, so probably this is VT. And this was the ECG showing previous AMI. Similarly, another patient with previous AMI, in the V1, we see the RBB morphology with a slurring. Now, one important point, what I have missed here, that we should look at the AVR, both in this as well as this. If the AVR is monophasic and positive, it means that the impulse is coming from below upwards, so the AVR is positive. And here also we see that along with the RBBB, there's a QS complex in V6 with a left axis, extreme left axis. So these are all suggestions of ventricular tachycardia. Now, one important point is that often when we see these patients, we try to revascularize these patients. But only revascularization helps only 5% of these patients, so we need to take care of this tachycardia separately. And these are all macro-reentrant in the sense that the current flows around the scar. When it is within 5 to 6 hours of the onset of the ischemia, then those are polymorphic VTs, and they can be revascularized by, and we can take care of the VT. But after the 5 to 6 hours, or even after 24 hours, when the scar is set, we have to take care of the VT as a secondary prevention. We should go for ICD, we should go for drugs, and if they do not work, we can go for even for ablation. And taking care of sodium, potassium, magnesium also, it helps only 20% of the patients. So this was another patient. This is the AVR, what I wanted to say, the monophasic R, or there is a QR, the Q duration more than 40 milliseconds, or there is a slurring of the descent in the QS if it is more than the ascending limb. So these are important. So this is another patient which is a wideish tachycardia. It is not that wide as the previous one. Now the Brugada criteria doesn't fit in here. There is no AV dissociation, no concordance, no R2S more than 100 milliseconds. So we are in confusion. We look at the AVR, that is also not very clear, but the axis is definitely superior axis. So in these patients, what we can do, we can set in the SVT, that is, we can, as in the guidelines of SVT, we can give some carotid massage to the patient. This patient was not helped by that. We gave adenosine to the patient, and there was more V's than A, so we were sure that diagnosis was ventricular tachycardia. We couldn't manage the patient. We gave amiodarone, then we went for DC cardioversion, and there we made the mistake, and the patient became worse. So then in retrospect, we thought that because there is RBB with superior axis, probably it's a fascicular VT. Not going into the mechanism of that, but we should take home message, have here that we should never cardiovert these patients, and calcium channel blockers, as we know.
Sir, is there a delta wave there, and there is a splintered, see the delta wave in C1? Yeah.
C1.
Because P waves are not seen anywhere.
Right, madam, it may be
Or
there.
it may be a junctional rhythm or...
So maybe some amount of myopotential is also there included within it, that is causing
because splintering of the
Yes.
descending limb of the
Yes.
R, it is more in favor of WPW.
Okay. Huh. Right. So then we gave verapamil to the patient, and this was the sinus rhythm for the patient. And then next. So this is a thing which is being talked about all by our senior teachers, that VPCs, Bijaminis, how do we treat that? Two questions to be answered. Number one, should we treat it? And if we are to treat, we should know the origin of the VT. As we know that if it is RBBB, it has got LV origin. If it has got LBBB, then it has got RV origin. But beyond that, if you look at the transition of the ectopic is earlier here compared to that of the sinus rhythm. So probably it suggests ventricular, left ventricular origin, and because 2/3 is down, it's up, so probably it's going down, so it is an LVOT VT. Now, the second question is that if there is a PVC burden is high, if it's more than 10%, but we have seen even up to 20% there is no bad effect, but in general more than 10% presence of NSVT, couplet, triplet of variable morphology. As we see here, the morphology varies. I'll show you in the next slide. Then there is short coupling interval, lack of circadian rhythm, variability, VA conduction, interpolated VPCs. These are also markers of LV dysfunction, and the patient may become symptomatic for that, and we need to treat them. So this, I was talking about the two VPCs of different morphology having a sort of RNT phenomena, and then it is degenerating into a ventricular polymorphic VT. So intelligently, if we can suppress or ablate these VPCs, probably this won't be there. Now, another important issue is that if we have LVV morphology with an inferior axis, is a structurally normal heart with a history of syncope in the family or family history, we think of two diagnoses. One is ARVC, or the other is idiopathic right ventricular outflow tract VT. Now, ARVC is very important because of the high mortality, or it's a dangerous one, while the other idiopathic VT is benign. So we need to diagnose it. So there are certain points like in the AVL on AV and lead 1, if there is broadening as well as there is notching, probably it favors ARVC, and also a late transition. It's not very clear here, the late transition in V5, V6, that is important. If there is a superior axis, in that case, we have to look for the multiple morphologies of the VPCs. That is important. Now, in the baseline ECG, not after DC cardioversion, in the previous baseline ECG, if we see such T-wave inversions persisting up to V4, that is important. We should keep in mind that maybe it is a case of ARVC. The other points like epsilon waves, if we find, we are fortunate. Now, this is accelerated idioventricular rhythm. This is basically a ventricular rhythm, slow ventricular rhythm going ahead of the sinus rate. The sinus bit, basically it is being suppressed by this. Now, these are basically hemodynamically, these patients are stable unless they are dependent on the atrial kick or they continue for a long time, which they usually not. And if they continue and the patient becomes symptomatic, in that case, we can give some atropine or atrial pacing that will manage this. Then we have the narrow QRS tachycardia. Here, if we see it nicely, then we see that there is a pseudo R and there is a pseudo S in lead 2. So probably this narrow QRS regular tachycardia, P waves may be there, so we think of AVNRT. So just for the teaching reason, I have kept this slide. As we have been seeing it, that during sinus rhythm, there is a fast conduction through the fast pathway, it gets conducted. Once there is an ectopic, because the fast pathway has got a more refractory period, it gets obstructed here, goes down the slow pathway, and from the slow pathway, it goes up the fast pathway. So because from the ventricle to atria, or sort of from below upwards, it goes from the fast pathway, so it's a short RP interval. And from above downwards, it goes by the slow pathway, it's a long RP interval, rather it's a short RP, tachycardia, typical AVNRT. So after we gave adenosine to the patient, this was the rhythm. Now, intentionally I have put it here, just we kept a catheter in CS, and if you see the ventricle, and this is the atrial signal, it is falling on the ventricular signal. So basically, what we have here, both the ventricle and atria, they are being simultaneously depolarized. Unlike, so the circuit here is in parallel, while in AVRT, the circuit is in series. So we see it in a different pattern. So what do we see here? Here we see, it's again a narrow QRS regular tachycardia where rate is around 170-80. The P waves are not very clear here. So what we do here, again we give adenosine to the patient, and we see that there in the V1, we see that there is delta wave and there is short PR segment. Yesterday I was discussing with my students that why there is a short PR segment and why there is widening. The basic reason is that because the accessory pathway is directly stimulating the myocardium, so there is a widening, and the PR segment is short because the accessory pathway has got a fast conduction property compared to the AV node. And what is the localization? The localization is definitely left side because the delta wave is positive and R is more than S in V1. So this is the electrogram of the patient. If you see here, this is the V, and the next is the A. In the CS1, 2, which is the distal CS slit, there is disclosure, while in 9 and 10, they are separated, so it's a left lateral one. This is a very common thing what we often being taught from our students earlier days from the MBBS career, that there is a wide QRS irregular tachycardia. So this is atrial fibrillation having an antidromic property, so going down the accessory pathway. The only drug we should keep in mind that the only drug we shouldn't give in these patients is adenosine because it will create more AV nodal block, the atrial refractory period will be reduced, and there will be further increase in the AF rate, and the patient may degenerate into VT and VF. This was the patient after DC cardioversion. Now we have another ECG. This is a narrow QRS tachycardia. This is a narrow QRS tachycardia. The P waves, if we follow the P waves here in 2, 3, and AVF, each QRS is preceded by one Q P wave, and those are negative. So narrow QRS, regular tachycardia, the P wave is morphology is different from the sinus rhythm. So this is basically a atrial tachycardia. So what type of atrial tachycardia? This is a focal atrial tachycardia. Why is it not a macro-reentrant one or circuit of atrial tachycardia? Or why is it not atrial flutter? Keep it in the other way. So because in atrial flutter, what we get is a reentry circuit, it's a macro reentrant circuit, the atria is being continuously being depolarized, while here the this in focal atrial tachycardia, it's an impulses, one after another. So in between, unless the atria is not being continuously depolarized, so there is an isoelectric line in between the P waves. The next question is that we cannot manage this patient with medical management. So we should know how to manage it by ablation. So one is localization. The other issue is that if it is at all a focal atrial tachycardia, can we differentiate the mechanisms, whether it's a focal, it's a automaticity triggered, or it's a micro-reentrant. So some simple approaches are there. They are not absolute. what we can do, give some adenosine to the patient. If it terminates, keep it in mind that it is a triggered activity. If there is AV block, in that case, then there is a persistent tachycardia. In that case, we can consider it as microreentral. And in case of sinus beat, or if it is atrial tachycardia due to automaticity, then there will be deceleration followed by there will be reacceleration. So this is one point. There are other points regarding defibrillation. There are other points regarding the warm-up phenomena. I'm not going into the detail of that. The second thing is that what we see here, the V1, now regarding the localization, the V1 here is positive, so it is something coming from left to right. The P waves I'm talking about. Then we look at the 2-3 AVF. They are down. So it is coming from below up. So in that case, it may be that it is a coronary sinus. It is arising somewhere in the coronary sinus, be it ostium or in the body. Now, another important issue is there when I was discussing atrial fibrillation, atrial flutter. So often we see, I don't have that ECG now, often we see that there are certain atrial flutter fibrillation in the same ECG. I never understood during my student days till now why such changes should occur from this to that, because anatomically they are different. The only reason could be that there is a micro-reentrant circuit for the atrial fibrillation, and there is a macro-reentrant circuit for the atrial flutter. But why should there be a switchover between the two? I don't know that. Probably my electrophysiologist friend could better explain that. And this is, as we know that this is at MAT, because the P waves in the different morphologies, in the different times, at least 3 different morphologies. So multifocal atrial tachycardia. And what is the difference between this? This I have taken from the textbook. The P waves are also different here. Only the difference between MAT and wandering pacemaker is that the rate. The rate in wandering pacemaker is lesser. In MAT, it is higher. Then I switch over to the bradyarrhythmias. This is complete heart block because the RR interval is fixed, the PP interval is fixed, and there is low relation between the P and R, so the PR varies, and the QRS is lesser than the number of P waves. Then the second degree heart block. So any non-conducted P wave is secondary heart block here. Here, if you look carefully, we see that the PR segment is gradually prolonging, and there's a drop bit. So it's a Mobitz type 1 block. If we look at just keep a catheter in his, and we measure the AH, this is the A, this is the H, this is the H, AH interval, and another thing we measure the H, and then the onset of the QRS, that's the HV interval. What do you see here? This again I have taken from the textbook of Braunwald for better understanding of the first case, that is a Mobitz type 1 block. We see that the AH interval 280, 290, 295, 295, 325, and then there is an A and there is no H. So this is a suprahischian block. I have intentionally avoided the term intranodal or AV nodal or below the AV node where there is some confusion there. And then I have a second degree AV block. This is we see that the PR interval here is fixed, and there is a P non-conducted. So what is the situation here? Here we see that the AH interval remains fixed, and after the H, there is a no V. So that is a below infrahischian block, and that is a Mobitz type 2 block. Now, here is another such scenario. Suppose we have some PQRS, and certain drop bits are there, the P is not conducted. Now we run a confusion whether it's Mobitz type 2 and Mobitz type 1. So the tricky way could be to answer this. If you look at the PR segment of the drop after the drop bit and compare with the PR segment just before the drop bit, and if they are same and fixed, so we can consider it to be Mobitz type 2 block. Had it been more than this, probably it could be Mobitz type 1 block. Now, 2:1 AV block, it has been kept as a separate entity, particularly because we do not have 3 Ps or at least 2 QRS to analyze it. So 2:1 AV block, it can be different from the other twos. So one probability is that if the peer interval is less than 160 milliseconds, it has been suggested that it is probably Mobitz type 2, or if it is more than 300 milliseconds, it's probably Mobitz type 1. And also the QRS duration matters. If it is wider, it's Mobitz type 2. And finally, I have a patient who came with syncope, and there is, we went for SNRT in these patients because we are thinking of sick sinus. I'm not going into the details of the history. So what we do here, we gradually decrease the stimulation rate from the sinus about 30 milliseconds each by 50 cycle lengths lower. And then we saw, and if we stop it, we see the escape rhythm. The escape rhythm is here, and the escape rhythm is here. We see that it is around 2717 milliseconds. The corrected SNRT will be from, if we minus this portion from this, there's 121240 from this, then we get 1477 milliseconds, and that is more than 500 milliseconds, and that is a feature of sick sinus syndrome. So that is AVNRT is positive. One point to be taken care of, that this is a feature of automaticity of the SA node. It doesn't talk about the sinoatrial conduction time. So if SNRT is positive, it may be false positive due to different reasons. So that is the thing, that is the, those are the basic ECGs I have prepared for you. Thank you.